This video is going to be on substance use. Now, when we talked about schizophrenia, we talked about substance use. We talked about how some substances can cause hallucination that looks like schizophrenia, and then also some substances can increase your risk of schizophrenia, like LSD. And then when we talked about personality disorders, especially cluster B personality disorders, we talked about how they're at risk of substances. So I think it's just fitting we take a little time to talk about substance use in our psychiatric block. So just to clear some terminology, when you use a substance that's out of its normal frame, or if you're using way too much or at an increased dosage, we call that substance abuse. And when you're using a drug in a way it shouldn't be used, or especially at a higher dose, your body will start to get used to that. Yeah, your body will start to tolerate it more. That same dosage won't elicit the same effect, so the patient will start to have to take higher and higher dosages. We call that tolerance. Your body just tolerates it more. And not only does your body tolerate it more, it starts to think, oh, this drug is normal. This is a normal part of my physiology now. It starts to incorporate it. And your body only functions normally with that drug in it. It starts to depend on that drug. We call that substance dependence. And if you take away that drug, if you withdraw that drug, your body freaks out, doesn't know what to do, starts eliciting symptoms. We call that withdrawal symptoms. And oftentimes the withdrawal symptoms are the opposite of the symptoms that the drug creates. And that shouldn't be a surprise. If I give someone a drug that lowers their blood pressure and I take away that drug, their blood pressure will skyrocket. So it's not exclusive to illicit substances, it's from any drug. So just keep that in mind. Withdrawal symptoms are the opposite of what the regular drug symptoms are. So withdrawal is opposite. So if a drug causes diarrhea and you take it away, then they get constipation. If a drug causes someone to sleep and you take it away, then they'll have problems sleeping. So just keep that kind of golden rule in the back of your mind when we're talking about some of these drugs. So let's talk about some of these drugs. The first group will be stimulants. Now stimulants, you can have illegal stimulants like cocaine, methamphetamine, ecstasy. All these seem to increase dopamine and give you this really big high, this euphoria feeling. However, you should also know that cocaine, the more specific mechanism of cocaine, is that it blocks reuptake of dopamine. So if this is your neuron releasing dopamine, then cocaine would block its reuptake. They like to quiz you every now and then on the exact mechanism of cocaine because cocaine is such a big one. Something else it does is not entirely specific to dopamine. It can increase norepi, and that increases your sympathetic drive, so you can get things like pupillary dilation, tachycardia. You can have really intense focus. Remember, stimulants like amphetamines is used for ADHD, so focus. Norepi causes vasoconstriction, so hypertension is a big symptom. And a lot of other heart problems, arrhythmias, you can imagine your heart beating like crazy. Arrhythmias. And a big one that cocaine is associated with is MI. You gotta know that code. A lot of times to talk about a patient coming in with bleeding nostrils from cocaine use. You might not say they're using cocaine. Tremors, pupillary dilation, tachy, and they had acute chest pain. What do you expect to find? They're basically saying, what do you expect to find because this patient had MI? So SC elevation, increased troponin, and all that crap. So just know cocaine in particular is a big cause of MI and substance abuse. Now, what kind of symptoms would you get in withdrawal? Then we say it's the opposite. So instead of dilation, you get pupillary constriction. Instead of that euphoria, that high from the stimulant, you get depression, really depressed mood. And they can be fatigued and sleep a lot. So just kind of the opposite of your regular symptoms. Those are illicit stimulants. You can have legal stimulants. What are some legal stimulants? How about the best friend of a lot of medical students, coffee? If you drink too much, you can get jittery, you can have trouble sleeping, insomnia. If you drink too much, you can have arrhythmia. So moral of the story, don't drink too much. Withdrawal symptoms, you have opposite effects. So you'll be depressed, tired. A lot of these patients complain of headache. For those watching that might always drink morning coffee, if you miss that morning coffee, how do you feel? It would be easy to remember the withdrawal symptoms of coffee. So another one is nicotine. Now nicotine is weird because it's a stimulant. However, at low regular doses, like if you're smoking, it's kind of a relaxant also. So they're relaxed, but if you take a lot of nicotine, then that stimulant effect will really kick in. You'll get jittery, you'll get anxiety, all the regular symptoms of stimulants, okay? So when they're talking about stimulants, they're not just talking about the illicit cocaine, methamphetamine. Don't forget coffee and nicotine are one also. Let's move on to our next class of drugs. This would be your depressants. And if coffee was a BFF of med students, then this will be a close second. Alcohol. Alcohol increases GABA signaling. Recall, GABA is our inhibitory neurotransmitter, so when you have increased GABA, you're going to have increased inhibitory transmission. So you have depression. At low doses, you'll have motor depression. In higher doses, once it starts penetrating your inner ear and your endolymph, you'll have vertigo, so the room's spinning everywhere. At higher and higher doses, you'll start to get really depressed. You'll black out. And then at really extreme toxic doses, you'll have respiratory depression, death. So what do I want to write here? Just write depression, even death. Now alcohol builds up really quickly because it gets excreted in the body in a fixed rate. We call it zero order kinetics. So let's just take, for example, this is just an example, this isn't real. Your body excretes alcohol at 1 beer an hour. No matter what, no matter how much alcohol you drink. So if you drink 2 beers an hour, it'll still excrete at 1 beer an hour. If you drink 10 beers an hour, it'll still excrete at 1 beer an hour. So because it excretes at a fixed rate, very easy for toxicity to build. Well, the withdrawal symptoms, it'll be the opposite of this. So instead of depression, you get really increased excitatory transmission. And you should probably know the pathophys for this. If this is your GABA releasing neuron, and you're releasing a ton of it to your receptors, eventually your body gets so overloaded that it will say, I'm going to have to downregulate my receptors just to function. So it starts to downregulate its receptors and you're left with very few GABA receptors. Now, when you take that drug away, it will cause withdrawal symptoms. So if a normal patient's inhibitory levels right here and his excitatory levels right here and is nice and balanced, well, when you're starting to use alcohol and you're starting to increase GABA, your body will downregulate it to try and compensate for the increased GABA. And if you take away alcohol, then you have way too much excitatory transmission. It's way unbalanced. Way too much excitatory transmission, and that's what causes the withdrawal symptoms that you see. And these include things like tremor. You're gonna have so much excitatory stimulation in your brain, you're gonna have things like hallucinations. Most commonly tactile hallucinations, they're feeling like their ants are crawling all over them. But the biggest and the worst when you have so much excitatory stimulation is seizure. That is what can kill patients. So that is very important that you know it can cause seizures. You can also have delirium, in a delirious state. Now, how do you treat that? Well, you're gonna have to give them some GABA. You're gonna have to kind of build back up that inhibitory levels. So you give them a GABA agonist, just for the time being, just so they don't seize out and die on you. So you give them an GABA agonist, usually in the form of benzodiazepines. And the doses of these benzos are quite high, like way higher than you would give anywhere else, but you're trying to make sure they don't die from seizures. So you bring back up that inhibitory level until it's nice and even, and then you can kind of wean them off later. But in the acute setting, give them those benzos. A lot of questions I've gotten on alcohol withdrawal symptoms are cleverly disguised. They won't tell you the patient was an alcoholic. They'll just say they came in for surgery, and then once they were done with surgery, they were put in the bed, allowed to rest. And because they were in the hospital and they weren't allowed access to alcohol, they'll start having withdrawal symptoms. So a couple days later, they'll start having tremors. A few days later, they'll start seizing. They might go into a delirious state. Then they ask you what's going on, alcohol withdrawal symptoms. Or they might ask you, what do you do about it? Benzodiazepines. Or they ask you, what's the mechanism of this? Downregulation of GABA receptors. So very important you know this. We never want them to get to this level. We never want them to get to being so much of an alcoholic that if you withdraw them, they can have seizures. So we'll try and intervene, try and wean them off, try and treat them for their substance use and substance dependence. Some things we can do. We can do counseling, of course. And then we'll try and wean them off slowly. Some pharmaceuticals we can use, disulfiram. What does disulfiram do again? If you recall, alcohol gets turned into acetaldehyde, and that becomes acetate. Now, acetaldehyde is incredibly toxic. It's what causes us to have those hangover symptoms, causes us to be very sick. Now, this gets turned into acetate by acetaldehyde dehydrogenase. Disulfiram blocks this. Why the heck would we block this and build up these toxins? Because when we build up those toxins, as soon as they drink, they just feel like crap. And it kind of takes away that pleasure of drinking and negatively enforces drinking. So these patients will drink less. You kind of slowly wean them off. So that's the role of disulfiram. You can also give things like agaprostate. Mechanism unknown, so nice, you don't really need to know how it works. Naltrexone blocks an opioid receptor. That's funny. Why does it do that? I'm not quite sure, but it seems to reduce, again, the positive feelings of drinking. So if you reduce that positive feeling of drinking, then it's easier to kind of wean off of drinking. So we want to talk to them early, console them, try and wean them off so they never get to the point of withdrawal symptoms, seizures, death. Okay? Now we're not done talking about depressants. There's another big group of depressants that we need to talk about. And we kind of touched on it here. It's another drug that works on GABA. So I just want to talk about how GABA works in some parts of the body. So you have this giant chloride channel that GABA binds to. So we'll just call it the GABA chloride channel. And we'll just say it's the GABA binding site. So when GABA binds to it, the chloride channel opens and causes inhibition. Now there are some other drugs that can bind to it. You can have a drug that binds to it called barbiturates. And when barbiturates bind, it causes the channel to prolong its opening. So it opens for longer, causes more inhibition. Now benzos can bind. And when benzos bind, it increases the frequency. So it opens more frequently, causes inhibition. So a couple of different mechanisms can open it for longer, can open it more frequently. The memory aid that's been taught for a long, long time is that Barbara likes it longer, Ben likes it more. A little bit of sexual connotation, but it helped me remember it really well. So Barbara likes it longer, meaning the channel's open longer. Ben likes it more, so frequency. But they do the same thing, potentiate GABA. And by potentiating GABA, causes that depression. Okay? Now let's say a patient uses too much and they OD on it. How can we treat that overdose? Well, for barbiturates are acidic, so we're going to want to alkalize the urine. Alkalinize the urine. And that just kind of helps excretion of it. So we give sodium bicarb. Benzos have a specific drug called flumacenil. And this is a competitive antagonist. So if you have an overdose of benzo and there's a ton of binding, you give flumacenil, this drug, and it'll come in competitively antagonize it, kind of help with that overdose. That's the overdose. Now, if you withdraw that drug from the patient and they have withdrawal symptoms, what do you think the withdrawal symptoms will be? Well, it does the exact same thing. Increases GABA, so the withdrawal symptoms are the same as alcohol, and it can cause seizures. Withdrawal symptoms are never good for any drug, but know that for depressants like alcohol and benzos, withdrawal symptoms can cause seizures and kill you. So withdrawal symptoms of any substance isn't good, but withdrawal symptoms in depressants can kill you. So all right, depressants kill. Kill. That's ominous enough. Hope you remember, okay? I think that's all I want to talk about when it comes to depressants. Let's talk about opiates. Opiates is a big topic nowadays because we're in the middle of an opioid epidemic. Prescribing too much, people are getting addicted. Unfortunately, opioids are the most common cause of overdose death. Yeah, very, very unfortunate. So if you don't get a question on it, I'd be very surprised. And if you're not asked about it, I guess in practice, I'd be, again, very surprised because it's a raging epidemic right now. So let's talk about opioids. Opioids relieve pain. They bind to something called the mu receptor. We make opioids, endogenous opioids, things like endorphins, which endorphin, the name comes from a contracted form called endogenous morphine. So endorphins, all these things we make in our own CNS and our pituitary to kind of alleviate pain. So we found out, hey, those things work pretty well. Why don't we synthetically make it kind of alleviate pain, and they alleviate pain by binding to the mu receptor. So synthetic forms are things like morphine and oxycodone. Illegal substances are like heroin. So again, if we're talking about an opioid epidemic, a lot of these patients are given oxycodone, get addicted, can no longer access it, so they move on to heroin. And symptoms include things like depression. Medically, if we're not talking about substance abuse, medically it can cause constipation, so decreased gut motility and constipation. If you give opioids post-op to alleviate pain, you basically know you're giving the patient constipation. You give them stool softeners almost prophylactically. Is that common? If the patient is using heroin, they have all that increased risk of using needles, dirty needles. So bacteremia, endocarditis, HIV, hepatitis, all those things. So heroin is even worse because you have all that exposure to bacteria and viruses. HIV is not a bacteria, so heroin puts you at an even higher risk of contracting something you shouldn't. So that's substance use. What happens if they OD? You're going to give things like naloxone. Naloxone is an antagonist. So the opioid binds on the receptor, then naloxone will come in, try and kick it off. Here's an important part that you should know. Naloxone has a shorter half-life than an opioid does. So you'll give a patient that's OD'd naloxone, they'll feel better. The respiratory depression will go away, they'll feel better. And here's the thing, you don't discharge them yet. Do not discharge the patient. Because if you discharge the patient will leave, and then the naloxone short half-life will cause it to go away before the opioid does. The naloxone will go away, and then the opioid will kick back in, and the patient will die. So I'll just write it has short half-life. So you might need to give more and monitor the patient. What happens with withdrawals? Withdrawal symptoms are very, very characteristic. I don't know the exact mechanism, but it's very characteristic. They're gonna have things like frequent yawning. Why they have that? Don't know, but frequent yawning is a huge one, and it's very easy to pick up on question stems. So much secretions. If this causes constipation, well, this causes things like diarrhea, all these rest and digest stimulations. So secretions, you get gut secretions, you get lacrimation, you get all these secretions. Piloerection, which is hair standing up on your skin, and dilated pupils. We talked about pupils before in withdrawals. What do we say? Cause changes in your pupil. We talked about that earlier. That was constricted pupils and stimulants. So there's dilated pupils and opioids. So that's withdrawals, that's OD. Again, we never want our patient to get to this point. We want to console them early, try and wean them off it. And we can do it with counseling. We can also add some pharmaceuticals. So some pharmaceuticals you should know is methadone. Methadone is a long-acting opioid. Why would we give opioid someone who has an opioid addiction? Well, there's a long-acting opioid, so when you're trying to wean them off it, you don't want to stop cold turkey. That's not a good thing to do. So you give this long-acting, slow opioid, kind of taper the dose, and this kind of gently weans them off of it. Naltrexone, we already talked about. That's a long-acting Now something else you can do is naloxone. Now we talked about naloxone. We said it straight up blocks it, which is stopping them cold turkey. That's not good. We just said it's not good for trying to wean them off. So we give naloxone plus something else, buprenorphine, which is a partial agonist. That just helps the transition be a little bit more gentle. Now let's say we finally got our patient off. Yes. How do we keep them from going back on? We want to give them something called naltrexone. When did we talk about naltrexone? We talked about it in alcohol cessation. We said it blocked opioid receptors. For some reason, it caused decreased positive symptoms. So here it blocks opioid receptors long term. So stops patients from relapsing. Those are your opioids. Just a few more to round things off. PCP. PCP works on your glutamate receptors. These are called NMDA, and it's actually an antagonist to it. How it causes its particular symptoms, I'm not quite sure, but you do need to know the particular symptoms. They are very, very important and almost specific to PCP. It causes hallucinations, nystagmus, in particular vertical, where your eye goes up, nystagmus. Very few things cause that. And more importantly, violent behavior. This is a drug that you'll see in the news. A patient will take it and then become very violent. They'll bite the roommate's face out. They'll fight police officers. They'll take like 6 of them to dive, tackle them. They're batoning them. They're tasing them. The patient just won't go down. It gives them this violent behavior and also this feeling of super strength and invincibility. So it's a double whammy, and they're very violent, very dangerous at this time. So PCP is known to cause that. All the questions I've ever gotten on PCP has never talked about a patient taking PCP explicitly. They'll just talk about someone that comes into the hospital delirious, hallucinating, very violent. That's all they say, and you have to infer they're talking about PCP. Or they'll talk about someone who's violent, delirious, with vertical nystagmus, PCP. Next up, LSD. LSD is a strong hallucinogen. I don't think I really needed to spend 10 seconds to talk about this. That's all there really is to talk about LSD. An important trivia fact, LSD has not been shown to be addictive, not been shown to cause withdrawal symptoms. There's some talk about using LSD in psychiatric disorders. Still up in the air, so just know LSD causes strong hallucinations. Again, if a patient comes in hallucinating, you're thinking of drug use, LSD, before you're thinking of things like schizophrenia. I think those are all the big drugs I want to talk about. I think this does it for this video. Hope you enjoyed. Thanks.